We have our chairperson for this session, Professor Hisham Abbas, and Professor Atif Mahmoud, and Professor Nirvana Magdi. Hisham.
Yes. Assalamu alaikum. We will start the second session of radiation therapy. It is my pleasure and honor to introduce one of the eminent professors in radiation oncology in Egypt, Dr. Mohammed Abul Futuh. He is a professor of clinical oncology at Manufia University, and his talk will be adjuvant therapy for endometrial cancer in the era of molecular classification. Please, Dr. Mohammed.
First of all, I would like to thank my colleague Khaled Abdelkarim who insists that I should present in this course despite our busy schedule. My talk is Adjuvant Therapy for Endometrial Cancer in the Molecular Era. Over the past 2 decades, endometrial cancer is the most common gynecological cancer among women in developed countries. We have a treatment shift for same for all to selected treatment approaches. We have randomized trials on rule of lymphadenectomy, laparoscopic surgery, radiation therapy, chemotherapy, immuno-oncology, and target therapy. And we have risk-based adjuvant treatment, and current directions concentrate on improved survival for high-risk patients, de-escalate treatment for favorable prognosis endometrial cancer, and decrease toxicity and enhance quality of life. And we integrated the molecular basis of endometrial cancer after the genomic atlas and the 4 new types of endometrial cancer. And we have new target for therapy. And then we end with individualized risk assessment using molecular characteristics. That's how we used to classify the patient with endometrial cancer into risk groups. The ESMO, ESGO, ESTRO consensus. That was the old consensus group. And in essence, it doesn't make a huge difference between the ESMO and GOG and PORTEC. It depends on the grade, depth of invasion, lymphovascular invasion, and this type of clinicopathological factors. It didn't include the molecular classification into this risk groups. These are the adjuvant radiotherapy for early stages, stage 1 and 2 endometrial cancer. We started with comparing external beam radiotherapy versus no adjuvant treatment, and we proved beneficial as regard local regional recurrence from the older trials, starting with the GOG, and to the most important one is the PORTEC 2, which changed the practice for high intermediate risk endometrial cancer. I will discuss it in more detail. And this is a PORTEC 2, the included patient with high intermediate risk according to the previous classification, and they treat them with vaginal vault brachytherapy versus external beam brachytherapy, external beam radiotherapy. And they managed to have a very low vaginal relapse with both the vaginal vault and external beam, and the 3 year of pelvic relapse was higher in the vaginal vault brachytherapy compared to the external beam. But there was no significant difference as regarding overall survival and relapse-free survival. So they come to the conclusion that vaginal brachytherapy is effective in preventing vaginal recurrence despite the slightly but significantly increased pelvic failure. but no significant overall survival and relapse-free survival. But the quality of life was superior with the vaginal vault brachytherapy compared to external beam radiotherapy. For this, we have this vaginal brachytherapy should be the treatment of choice for patients with high intermediate risk endometrial cancer. And the look at risk factors for the PORTEC 1 and PORTEC 2 study, and the identifying the lymphovascular space invasion as a risk factors for poor prognosis with patients with substantial lymphovascular space invasion, that is multifocal or extensive lymphovascular space invasion compared to focal or no LVSI as regard the pelvic regional recurrence and distant metastasis. And we have the 10-year updated survival. We have again equal vaginal recurrence between the two groups, and again still the pelvic recurrence is 6.3 versus 0.9%, but the distant recurrence was not different, and overall survival was not different. So still the initial analysis hold after 10 years of follow-up. They look at the impact of molecular subtypes on the results of PORTEC 2, and you can see here for the left-hand side survival curves. You can see the patient with polymerase epsilon ultra-mutated endometrial cancer is the best prognosis, while B53 apparent or mutant is the worst prognosis. And they looked at other factors like LVSI, B53 and L1CAM. They found that the worst prognosis if you have vaginal vault and one risk factors out of these poor prognostic factors. The long-term conclusions were long-term results of PORTEC 2 confirmed vaginal vault brachytherapy as adjuvant treatment of choice for women with high intermediate risk endometrial cancer. External beam might provide better pelvic control in the small subgroups of women with unfavorable risk factors, patients with substantial LVSI and L1CAM expression or B53 mutation. And this is the trials for radiotherapy and chemotherapy. They started with the older trials looking at like GOG 122, comparing whole abdominal irradiation versus idramycin platinol, and to the most contemporary studies like PORTEC 3, GOG 249, and GOG 258. I will discuss the most important, the last three, in the next slides. The PORTEC 3 look at patient with high risk stage 1 and patient with stage 2 and 3 and non-endometrioid endometrial cancer like serous and clear cell, and they give them pelvic radiotherapy versus pelvic radiotherapy concurrent with 2 cycles of cisplatin and 4 cycles of carboplatin paclitaxel. The primary endpoint was overall survival and failure-free survival, and this was the overall survival benefit was 5% in the chemoradiotherapy compared to radiotherapy, and failure-free survival was 7%. But when they look at stages, early stages, stage 1 and 2, they do not benefit from adding chemotherapy. Compared with the stage 3, the benefit is around 10% for stage 3, and the p-value is significant. So if you giving concurrent chemoradiotherapy, it should be for advanced cases like stage 3 or 4A or similar. And for failure-free survival, again, we have for stage 1 and 2, 4% difference, but for stage 3, it's 12.5% difference. And also for the pathological subtypes for the serous group, they have 5-year overall survival, 71.4% compared to 52.8%, and also failure-free survival was significantly different for the chemoradiotherapy. So for patient with high risk pathology like serous and patient with advanced stage, it's better to give concurrent chemoradiotherapy. And patient with early stage, you can skip the high risk early stage, you can skip the chemotherapy for adjuvant treatment. And then we look at the molecular classification of PORTEC 3 trial for the high risk endometrial cancer, impact on prognosis and benefit from adjuvant therapy. Again, the best prognosis were the polymerase epsilon ultra mutated, and the worst prognostic factor was B53 apparent or mutated, both for relapse-free survival and overall survival. The 5-year relapse-free survival for the B53 apparent was 48%, and for the two intermediate risk groups like the MMRD and non-specific molecular subtypes, it was around 72 to 74%, and the best was the polymerase epsilon was 98%. And they look at the effect of chemotherapy, chemoradiotherapy versus radiotherapy on the molecular subtypes. And the group that benefited from chemotherapy was the B53 mutant cases. You can see here that there is significant improvement as regard the overall survival and relapse-free survival for adding chemotherapy. But for the polymerase epsilon ultra-mutated cases, there is no benefit of giving concurrent chemoradiotherapy or chemotherapy for these cases. For the MMRD endometrial cancer, there is no benefit of adding chemotherapy. In the non-specific molecular profile, there is a trend for relapse-free survival, but overall survival was not significant. But this warrant further study to confirm that this group will benefit from the chemotherapy or not. And we come to the GOG 249 and GOG 258. 249 is for stage 1 and 2 high intermediate risk factors, or stage 1 and 2 serous and clear cell. They compared pelvic radiotherapy versus 3 cycles of carboplatin, paclitaxel, and vaginal vault brachytherapy. And for the GOG 258, it was for advanced stage 3 up to 4A, comparing the PORTEC 3 protocol versus 6 cycles of carboplatin, paclitaxel. And this is the GOG 249. The only significant difference was the increase in pelvic relapse when you give vaginal vault compared to pelvic radiotherapy. The other, there was no significant difference as regarding para-aortic or distant failure. And here the overall survival was similar, and the incidence of, as I mentioned, distant relapse was slightly higher. However, adverse events were more common and more severe with chemotherapy plus vaginal vault brachytherapy, 94% compared to 44%. And the quality of life, physical functioning at 6 months was worse in the chemotherapy arm, and a 10 versus 1% sensory neuropathy at 24 months, and no difference in 5-year distant recurrence. So pelvic radiotherapy alone remains a standard of care for stage 1 and 2. And we come to the GOG study. There was no difference between the chemotherapy alone and chemoradiotherapy, but we have less vaginal recurrence with radiotherapy compared to chemotherapy alone, and also less pelvic and para-aortic recurrence. However, there was the distant recurrence was higher in the chemoradiotherapy arm, but that wasn't significant because if we look the hazard ratio, it included the one in the confidence interval, so it wasn't significant. So we have better pelvic and para-aortic control with chemoradiotherapy versus chemotherapy alone, Neurotoxicity was worse in the chemotherapy arm compared to chemoradiotherapy, but gastrointestinal symptoms were worse at 6 weeks and 18 weeks, were significantly worse with chemoradiotherapy compared to chemotherapy alone. So the conclusion from the 3 trials, for stage 1 and 2 endometrial cancer with high risk factors, a small failure-free survival benefits seem not to outweigh the toxicity of adding chemotherapy. Across trial, excellent pelvic control with radiotherapy alone. For stage 3, combined chemoradiotherapy schedule provides significant 10% overall survival benefit and 12.5% failure-free survival improvement. Combined chemoradiotherapy versus chemotherapy alone, significantly better pelvic and para-aortic control. Then this is the diagnostic algorithm for classification of the 4 molecular subgroups in endometrial cancer. First, you do the polymerase epsilon testing. Then after that, you test for the MMR either deficient or proficient. And for the proficient, you can look at the B53, and then you at the end you have the 4 groups. You do polymerase epsilon first because they found that if you have MMR or B53 as a secondary event after polymerase epsilon, it doesn't affect the prognosis, and still the prognosis is very good in these cases because they have a lot of mutation occurs because of the molecular process. And this is the molecular and clinical characteristics of the endometrial cancer. The polymerase epsilon tend to be stage 1 and 2, and high grade, and despite it is high grade, it carries the best prognosis because it has stimulate the immune response and has prominent tumor infiltrating lymphocytes and carries the excellent prognosis, almost 100% overall survival. And then for the MSI high or deficient MMR, this represents around 30% of the cases. It usually to be endometrioid, often high grade. LVSI is substantial. They have prominent tumor infiltrating lymphocytes, usually with Lynch syndrome, and you can test by MMR by immunohistochemistry for the 4 markers, and it carries intermediate prognosis. And for no specific molecular subtypes, this is the most common subtype of endometrial cancer, around 30 to 40%, and this is what we call that has somatic copy number alteration low, mostly again endometrioid, and it has ER and PR diffuse staining, and this will affect the further studies, which will include hormonal treatment I will discuss in few slides. And then we come to the worst prognosis, the B53 apparent, around 5 to 15%, and it has the somatic copy number alterations high, and it includes all histological subtypes with low level of tumor infiltrating lymphocytes and carries the worst prognosis among endometrial cancer. And this is a new ESMO, ISGO, ESTRO classification. They included they have 2 classification if you have molecular subtypes known or molecular subtypes unknown. And please note that if you have a stage 1A B53 abnormality, you can still include it as intermediate risk, but after stage 1A, it is included as high risk patient. There is change from the previous classification. Stage 1B grade 3 and stage 2 moved from high risk into high intermediate risk group. And this is the recommendation from the ESMO ISGO recommendation for adjuvant treatment. For low risk patient, no adjuvant treatment. For stage 1B, for intermediate risk, they give adjuvant brachytherapy and recommended to decrease vaginal recurrence. Omission of adjuvant brachytherapy can be considered, especially for patients less than 60 years. for patients with high intermediate risk, if they have N0 after lymph node staging, you can give adjuvant brachytherapy. Only external beam radiotherapy can be considered for substantial LVSI and for stage 2. Adjuvant chemotherapy can be considered for high grade and substantial LVSI. High intermediate risk without lymph node staging, you give adjuvant external beam is recommended, especially with substantial LVSI and stage 2. The other recommendation is similar to the previous one. For high-risk patient, external beam with concurrent and adjuvant chemotherapy, all alternative sequential chemotherapy and radiotherapy is recommended. Chemotherapy alone is an alternative. Carcinosarcoma should be treated as high-risk endometrial cancer, but not as a carcinoma, but as endometrioid carcinoma. And this is the molecular integrated risk profile for the PORTEC 1 and 2, and this will be the basis for the PORTEC 4A study. They have 3 risk groups. The favorable one was the polymerase epsilon mutation, and they included also microsatellite stability and catenin 1B exon 3 wild type. For intermediate group, they included the microsatellite instability and catenin B1 exon 3 mutation. And for the unfavorable group, this represents 5 to 15% of the cases. Patient with substantial LVI and L1 CAM more than 10% expression and B53 mutation. And this is the same cartoon showing the same risk group. And this is the PORTEC 4 study. The PORTEC 4 study for high intermediate risk that traditionally used to be treated with brachytherapy. Now they found, as I mentioned, more than 55% of the cases are actually favorable according to the molecular classification. And for this, they tailored the treatment into they have randomization to the standard treatment, giving vaginal volt brachytherapy versus individualized treatment based on the favorable group or intermediate or unfavorable. For favorable, they offer only observation. For intermediate, they give vaginal volt brachytherapy. For the high-risk patient or unfavorable, they give external beam radiation therapy, and then they follow up the patient and for quality of life. Then we have the project called the RAINBO project, or refining adjuvant treatment in endometrial cancer based on molecular features. The RAINBO umbrella program consists of 4 clinical trials investigating new adjuvant therapies in endometrial patients. Eligible patients will be assigned into 4 RAINBO trials based on the molecular profile of their cancer. B53 abnormal endometrial cancer patient to the B53 red trial, and the mismatch repair will be for the MMR deficient green trial, and no specific molecular subtypes to the orange trial, and the ball mutant endometrial cancer to the ball mutated blue trial. This is the RAINBO project. This are the collaborators for the RAINBO protocol. They have different treatment options according to each study. I will show it in this cartoon. For the B53 abnormal red trial, the N number will be 485 patients. They offer them the PORTEC protocol versus PORTEC protocol plus olaparib 300 milligram BID for 2 years. This is based on the results that they found that in TB53 mutant endometrial cancer, 46% of the patients have problem in the homologous repair. So they offered them olaparib as a maintenance for 2 years. And for the MMRD deficient green trials, because as I mentioned earlier, they will have a lot of mutation and tumor infiltrating lymphocytes, as I mentioned in the clinicopathological feature, They offered them immune therapy as a maintenance. After external beam radiotherapy, they will give them durvalumab, 1500 milligram IV once every 4 weeks for a total of 1 year. And for the non-specific molecular subtypes, the original, the orange trial, they will include 698 patients, because as I mentioned in the clinicopathological features of the molecular subtypes, it has progesterone and estrogen receptors, so they will add oral medroxyprogesterone acetate for 2 years after finishing the initial treatment. And they came to the blue trial. They include 100 patients with the polymerase epsilon mutated endometrial cancer. For stage 1 and 2, they will not offer any adjuvant treatment. For stage 3, it will be optional either to give no adjuvant treatment or give external beam radiotherapy based on the results of the PORTEC 3, because they have some patient with polymerase epsilon in that study. And my take-home message: first, a better selection for adjuvant treatment can be achieved when treatment is based on the molecular group. Difference in benefit of chemoradiation as compared to radiotherapy alone were found between the molecular groups. Strong and significant benefit for adding adjuvant chemotherapy in patients with B53 mutant cases, and MMR deficient do not seem to benefit from adding chemotherapy. Non-specific molecular subtypes, slightly higher relapse-free survival with chemoradiation that warrant further study. And implementation of molecular-based classification for all endometrial cancer depend on available resources. However, it might well prove to be cost-effective, as unnecessary or ineffective adjuvant treatment can be reduced. And thank you for your attention. For what cases?
For high-risk patients.
If it's in the recommendation, they give for LVSI, and they give external beam, and even they consider chemotherapy.
Addition of vaginal brachytherapy to external beam radiotherapy according to the new classification.
I do that for stage 2 only. Yeah.
Thank you.
Thank you.